Good morning and welcome. For those who don't know me, I'm Jeremy Veenstra Vanderwill, Director of Child Psychiatry here. And it's really my distinct pleasure to welcome you to the Viola Bernard Grand Rounds. Because I need to make sure I do the housekeeping stuff first, I wanted to let people know that next week will be a clinical Grand Rounds. There's no such thing as just meds from Jeffrey Taylor, our own resident, here with Steve Roos serving as discussant. And then for those who are interested, there is lunch after Grand Rounds today at approximately 12:30 upstairs in the multipurpose room. So because this is a special Grand Rounds, I wanted to say a little bit about Viola Bernard and thank the Viola Bernard Foundation for support of this Grand Rounds. Viola Bernard was a social psychiatrist, really dedicated to underserved families and youth over the course of her career. Paid a lot of attention to the ways that community health and individual health were intertwined, did work related to civil rights, urban poverty, and as described by one of the trustees of the Viola Bernard Foundation, she really had an enduring commitment to social justice and disadvantaged children. This fits perfectly with the mission of the Viola Bernard Endowment here, which funds both this Grand Rounds as well as a training program that accompanies the Grand Rounds. Really remarkable effort to bring evidence-based psychosocial interventions that Dr. Bernard cared deeply about into the urban underserved setting that we impact here in Washington Heights, but also reaching out throughout New York City, providing training to clinicians, and in this case, school providers, from administrators to frontline providers throughout New York public schools. So something that really makes a remarkable impact, something that we in the division and the department see as a real privilege to be able to provide this sort of training and see that impact spread. I want to acknowledge a number of folks who are in attendance. Others would be in attendance, but for the weather. So thank you to everyone who did make it, but particularly representatives from the Viola Bernard Foundation, the New York City Department of Health and Mental Hygiene, as well as the New York City Department of Education and the State Office of Mental Health, school and youth initiatives. We also have academic partners who are joining us today, both for Grand Rounds as well as throughout the afternoon. And perhaps most importantly, leaders from public schools here in New York City and community partners who are really on the front line bringing mental health impact into the school setting. And that's what we're going to hear about today. And then before I pivot to the introduction, I also want to thank Laura Muffson, but particularly Erica Chin, who really has spearheaded the Viola Bernard Training Initiative here within the division and the department. Erica serves as clinical director of psychology within New York Presbyterian Hospital and is just a huge force for good, impacting communities here within our department and broadly within the hospital system. So thank you to Erica for making this possible. And then I really have the distinct privilege, and it is uncommon that we get to introduce partners to present Grand Rounds, but distinct privilege to introduce Jim Mazza and Elizabeth Dexter-Mazza. So I'll give them individual introductions because that's the way these things go. But really remarkable partnership, bringing complementary skills into play to really make an impact for children and adolescents in school settings. So Jim did his master's and PhD at the University of Wisconsin at Madison, did spend a brief time at his alma mater, St. John's in Minnesota, before fleeing to the University of Washington, where he's risen through the ranks to full professor. He's a past president of the American Association of Suicidology and previously directed the Reconnecting Youth program, so really has been dedicated throughout his career to making impact for youth in school settings, as well as training school psychologists. He has been involved in the program that you'll see here and transferring that into the research and evaluation context to be able to understand how DBT Steps A can make an impact. And then Liz did her master's and doctorate at Pacific University, did an internship here in New York at Montefiore with Alec Miller, who you'll see is also one of the authors on the Steps A book, and then a postdoctoral fellowship with Marcia Linehan, who's well known as the developer of DBT. She became the clinical director within Marcia's behavioral research and therapy clinics at the University of Washington, continues there as clinical faculty, also directs a consulting service, does ongoing work with individual clients, but also works to really implement this approach that you'll hear about, DBT skills training for emotional problem solving for adolescents in the school setting. So we're really in for a treat, and without further ado, pleased to introduce Jim and Liz.
Thank you to everybody. I have to say this is a real honor for both of us that we get to come and talk to you. And my biggest challenge this morning is going to be talking slow and staying by the microphone because you all are recording us. So I'm going to notice I'm going to have urges to move around, but I'm going to try to stay over here behind this podium, which is not very common for either Jim or I to stand still in this way. But what we want to do this morning is to give you kind of an introduction to what this DBT Steps A curriculum is that we developed, why we developed it, how it came to be. I'm going to talk for about half the time, and then I'll switch and let Jim talk a little bit and kind of just give you some of the background for all of us on this as we kind of walk you through it. So kind of, just first to say, just thank you to Erica and Laura and Jeremy and everybody at the hospital here for bringing us out. This is just really wonderful to us. We've spent a lot of our time in New York in general. We live in Seattle, but we spend a lot of time in New York because of the schools in New York are really movers and shakers and thinking about social emotional learning. So this is common for us to be able to come back here, and we just really appreciate that. So thank you. So we always just start with our general disclosure statement that we are the authors of the DBT Steps A curriculum, so we are biased in what we're talking about today, just to put that out there for all of you. Okay, so this is the Viola grand round, so just kind of wanted to start us off with that for a minute, because when Jim and I were doing some research and trying to understand the meaning behind the foundation, we found this quote from Viola Bernard of events within individuals, interactions between individuals, and relationships among social institutions are all interconnected, subject to scientific inquiry, and in urgent need of rational management. Right? And that kind of quote, as we were looking at it, really just kind of pulled together this whole picture of us, of what we've been doing for so long, that we are a community and that we have to work at all levels of our community. As a clinical psychologist, and in all of my work with DBT and my clients, I always start out all of my relationships with clients is that we are a team. I am the expert in the treatment and you are the expert in your life, and neither of us can help you reach your goals without the other. I can't help you get to where you need without you being a part of this team. And I think this really translates into the work that we're doing with schools now and communities, because the communities are the experts on what they need. We're the expert in the development of the curriculum, in the treatments, but we have to work together as a team in order to actually make an impact. Just coming and saying, here, do this, without getting feedback and thinking about adaptations for each individual community is where we'll fall down. And so this whole mission of the Viola just kind of really fit, going from a clinical, what I do in an office with one person, to really what we need to be looking at with schools and communities, pulled it all together. So kind of using that as our lens, this just kind of is where we move forward and thinking about how do we get more skillful behavior, building resilience into our students in schools. So I just want to kind of put that there. And I want to start with kind of talking a little bit about how did we develop DBT Steps A? Kind of where did this come from? And so a little bit of background on me and Jim is that we are both psychologists. I'm a clinical psychologist. He's a school psychologist. And I was doing DBT for years and always working with adolescents when I was with Alec Miller and then in Seattle with Marcia Linehan. And I would have adolescents in my office. We're working on suicidal, self-injurious behavior, and Jim would come to me as a school psychologist. He's like, I identified that kid 4 years ago when I did my school-based assessments. I could have told you who was going to end up in your office. And he would get frustrated that how come I'm identifying kids and then it's 4 years later when things are really bad is when they're actually getting services met? And so we kind of started having these conversations about what do we do about this, especially because when we both started out as suicidologists, right? We met at the American Association of Suicidology conference. We came from a suicide prevention standpoint. And the question that kind of often came up for us is this idea of how many students are in a typical classroom. I don't know about in New York City, but at least in Washington, like a typical size classroom is about 30 students. In general. And we think about how many students attempted suicide in the past year in that classroom, we're looking at about 3 students in every class of 30 have thought about or made a suicide attempt in the last year. And that was back in 1997 when Cheryl King was researching this. And we know the suicide rates have increased in this age group. And so it really starts getting us thinking, like, we are in suicide prevention, and the only work we're able to do is he can identify them, but then 4 years later when things get really bad, they're in my office and I'm working one-on-one with one student at a time, becomes really difficult at making an impact. And so we started thinking about, okay, well, what are the risk factors? How do we talk about decreasing suicide risk factors in our teenagers and our students? And we started looking at all of them. Like, and you guys have all seen this, like prior attempts, non-suicidal self-injury, thinking about suicide, history of mental illness, impulsive behavior, a contagion effect, LGBT youth, family history, trauma, firearms in the home. Those are all risk factors. I look at those and I'm like, what are we going to do about those in a school-based setting? How are we going to treat that in the community? Like, we can do psychoed on firearms in the home, right, and do a decrease in that. Like in Washington State, they have a huge push from the state legislature that there's free lockup boxes, decreasing means as a way of decreasing suicide risk in Washington. I can't really address from a school-based setting, how do I stop trauma and abuse to decrease risk factors? So all these pieces started thinking about, like, how do I impact that? Becomes really difficult. We can talk about decreasing mental illness by improving skillful behavior, but it's not until we really start thinking about protective factors. What are the things that we actually can start thinking about how we make an impact? And so these are the protective factors put out by the American Association of Suicidology that we're really wanting to look at. And the items highlighted in yellow is where I think, from a school-based community place, we can think about how to make an impact. And we're looking at that with our Steps A curriculum. Family and school connectedness. How do we build a culture where people are connected, talking to each other, using the same language? Safe schools is, in general, how do we build safer school communities, especially in this day and age where we're having a lot of mass shootings and kids are just having this feeling of anxiety walking into a school building. We're seeing more of that every day. Reduced access to firearms. Improving academic achievement. By building skillful behavior and focusing on wellness, it also impacts academic achievement. Self-esteem, more support from family and peers. We know students talk to other students before they talk to adults. So if we're starting to, on a universal community base, provide the peers, the community, with more education and skillful behavior resilience, then we're increasing those protective factors as well. By building a safe and affirming school environment, building and teaching a more non-judgmental and accepting stance, using the non-judgmental skills and language of DBT is one of the ways that we can start looking at impacting that. And then presence of gay-straight alliance in school, family connectedness, and access to mental health care that meets the students' unique needs, which many of you in here are doing very well already with these targeted school-based mental health clinics that you have. But how do the idea of where can we make our impact if we really want to see overall decrease in suicide rates, but just increase in academic wellness and effectiveness in our schools? That's the kind of the lens we started taking on where do we go when we're developing this curriculum. So here's the million-dollar question. What do we actually do to help our youth, right? If we want to think about decreasing suicide, increasing resilience, and improving overall wellness in our students, DBT Steps A is not a suicide prevention curriculum, and I think we have the potential to have an impact there. So what do we have to do, which I think kind of fits with what we were talking about earlier with the Viola, is that we need to look to evidence-based interventions to guide us, right, through that. And so that's where we decided to look at DBT, partly because that was my expertise in the area that I work in, and DBT is shown to decrease suicidal behavior in adults and adolescents. And so it was developed, if we go to look to history, Marshall Linehan first published her manuals on DBT in 1993, and then updated her skills manual with a lot more depth and information in 2015. And then Alec Miller and Jill Rathis published their first manual on DBT for adolescents in 2007, and then their skills manual in 2015. And from that, we decided, okay, we do not need to reinvent the wheel. And we look at it that there are the adult DBT skills training worksheets and handouts. There are the adolescent worksheets and handouts. We did not want to develop a third set of adolescent handouts for schools, right? Because then it's like, who's doing what? We wanted to develop a continuum in our students. So actually, the handouts that are in the DBT Steps A curriculum are all from either the adolescent Miller and Rathis book or the Linehan book. So there is this continuum of whether our students are in inpatient treatment, outpatient DBT services, or in school, they're all getting the same skills, similar handouts with different fonts, and learning the same language. And we're kind of working to decrease that stigma over time of mental health. DBT is for kids with problems, but these are back to skills that we all need. Some of us learned them along the way, some of us didn't. So how are we as a community now going to teach these skills to every kid? Because in the end, for those of you who are familiar with skills from DBT, they are general effective decision-making, emotion regulation skills that we all use and we all need. What Marshall Linehan did was she organized them, she found evidence for all of them, she took the best skillful interventions of every effective treatment out there and put them into her skills manual, and credited everybody she took them from, but said these are skills that we all use. And now we're just going to make it in a very structured, formalized manner, give them names so that we can start using a common language. And now we're just generalizing that language from the clinical community into the general community is kind of our goal. And so as we were kind of looking through this and thinking about, all right, who are we going to target in schools by working on DBT skills in schools, Jim and I kept going back and forth over time of he wanted it to be, I'll kind of explain this for you a bit here. He really is like, we're both suicidologists. We want to decrease at-risk kids, get these skills to all of them. And then I would come back and say, well, why aren't we giving the skills to every kid? All I hear from my parents and my teenagers is, why aren't we learning this in school? These are skills that everyone needs. How are we getting it to them? And we'd go back and forth. And so we started to think about, how are we going to shift our lens, right? We need to really move our lens here. And I just love this quote that I always like to share with people. This idea that when I is replaced by we, even illness becomes wellness, right? As a clinical psychologist, I have always had the lens of mental illness. That is what I treat. And really shifting, if I'm going to move into a community approach and really thinking about prevention and going upstream, I'm not working on decreasing mental illness, I am working on improving mental wellness. And kind of thinking of that from a community perspective, that we really want to go there. And so from that conversation, Jim and I moved into even more in-depth conversations about, well, what are we doing in schools? And so let me talk about point B here first. So one of the things I had said to Jim when we were looking at this was, he's like, we're working with at-risk students. And I said, okay, make me a list of all the behaviors and problems that you think these at-risk students engage in. All right? So we know who we're going to be targeting when we're developing this curriculum. And so here's the list he came up with. Kids who could use these skills: those who struggle with alcohol and drug use, have difficulties with relationships, might be engaging in suicidal or self-injurious behavior, those with trauma histories, physical or sexual abuse, bullying, victimization or perpetration, homeless youth, antisocial or gang-related behaviors, students with academic pressures, students with identity struggles. He gave me this list, and I was like, okay, so which teenagers did you leave out? Right? Because on some level of continuum, all students, almost all people, deal with most of these difficulties on some level. And so this kind of came back to our argument of, yes, we need to get the skills to all kids, right? Because all kids struggle. Even like our valedictorians, our straight A students, the ones who are, captain of the football team, they're still struggling at times with peer pressure, with academic pressure, with sports pressure, relationship issues, that what if we start arming them all more effectively with emotion regulation and coping skills? And that became our focus of how do we actually make this a universal curriculum rather than a targeted curriculum within schools. And then the other thing we really spent a lot of time talking about is how current school structures are balanced, right? What's the focus of going to school is for academics, right? To learn how to do your math, your reading, your writing, your social studies, all of that. And what we were really finding is that it's a really unbalanced model in that schools really focus on academic side, and what we want them to think about is how do you bring in academics with social-emotional learning, right? It's not that we're saying 50% academics, 50% social-emotional learning, but more in the 80-20 or 85-15, that we actually want to start really thinking about how do we educate the whole child, not just the academic child. And that's where we spend a lot of time with schools, staff, and especially administrators on, what a lot of school administrators we talk about, what they care about is increasing the number of minutes in the seat in a classroom for a student, decreasing school disciplinary behaviors, and increasing GPAs, right? And so how do we help them to improve that? We've worked with several programs that were really focused on academic achievement, and there were like these after-school enrichment programs where they would, in inner city LA, where they took kids who were, nobody in their families have ever graduated from high school. They were really struggling in lower SES areas, and they focused for 4 years on academic enrichment. And they moved from like a 25% or like maybe like a 50% high school graduation rate up to 100% high school graduation rate, which was phenomenal for their program. But then as they started doing follow-up data, they realized they had about a 23% college graduation rate. That with all the academic supports in place, they were really able to get these kids through high school. But once they got off on their own, they didn't have the emotion regulation, decision-making capabilities to continue to maintain it and manage in a broader environment. And so pulling in the social-emotional learning piece of it is really the way that we've started to move to how do we prepare our children to not only get through high school, but actually to move out into the world and to go to college when they are more on their own. It's kind of, I think about it from a historical development side that, I probably grew up in the opposite of helicopter parenting age, right? My parents were super hands-off and like I was just expected to do things and I did them. To now where there's so much helicopter parenting, and I talk to parents who, are in touch with their kids' college professors, trying to get them extensions on papers and working on things, to how do we actually start going back to building the resilience, and even in parents also, so that they can actually start taking on some of those responsibilities themselves again once they get to college and beyond. So that's kind of where we come with pulling all this together. And so we then pulled out a DBT. And, these are the different components of a comprehensive outpatient DBT program in that we've got individual therapy that the client attends once a week. The therapist is on a weekly consultation team. The clients get 24/7 telephone coaching and consultation between sessions during the week, and they attend a 90-minute to 2.5-hour skills group once a week, right? That's a big treatment, right, for big problems, big behaviors. But like I said earlier, we know that the skills are effective, and we've got lots of data that show that the skills are effective alone in treating more universal, low-level problems. So that's where we pulled DBT out in our DBT skills group, and we started really thinking about how do we move upstream. So this is our upstream slide that we spend a lot of time. We've got kids who I spend a lot of time in outpatient DBT are coming to my office. But that's where problems are already really rocky. Life is struggling. They're having a lot of difficulties. Eventually, sometimes they either come to me or step up to going to IOP programs, partial hospitalization programs, residential treatments, or hospitalization, right, when things are getting really bad. We want to move backwards, and we want to get to where the waters are still calm, before they start hitting that rocky area, really moving upstream. And that's where really engaging the community and the schools is the place for that. And then even if we're, DBT Steps A is a universal curriculum, we know it can work for 80% of our kids. If they start to struggle, how do we move into what we call school-based DBT, which a lot of you have here already, is that you've got school-based mental health clinics. So how do we move under one roof where then we're able to offer comprehensive, effective treatments in the school-based setting where the students are already present? And so that's just kind of some of the background on where we started pulling all this together. And we developed the DBT Skills in Schools curriculum. Like I said, because it offers this upstream universal approach, we want to give all students emotion regulation skills. Who wouldn't benefit from emotion regulation skills? I mean, even all of you, and myself included, we are all high-functioning, successful, mostly mental health practitioners in here. Are you all emotionally regulated perfectly and skillful all the time? Right? If you are, please let me know what your magic is, right? But we all struggle. But we have the skills that we know that we can use when we need to regulate. So how do we teach this to all students in that way? Teach them to make more effective decisions. And by having it come from an evidence-based approach, we already are going through our history. We're using our scientific inquiry to know where to guide us on that. And especially when we're looking at the most lethal behaviors of non-suicidal self-injury and suicidal behavior, we can potentially have that impact as well when we're moving kind of to this more wellness and resilience model over time. And so just kind of to highlight one more piece, this idea that an outpatient skills group for DBT for adolescents teaches 5 modules of mindfulness skills, distress tolerance skills, emotion regulation skills, and interpersonal effectiveness skills. And then what was added in the adolescent model with Miller and Rathis was the middle path skills. And we included all of those skills in our curriculum except all of the middle path skills. In the middle path, one of the sets of skills are the dialectical dilemmas between parents and adolescents. Since we typically don't have parents coming into the school and sitting in class with our students, we left those out of there. Those are skills that we will tend to encourage schools in parent seminars to bring in and to educate the parents about on that. And then there's also a set of skills on validation. Now, we believe validation is very important. We teach about that a bit more in the interpersonal effectiveness skill base where it shows up there. But we did keep the skill of dialectics in and to how to teach students to engage in dialectical thinking. And it's actually the very first skill we teach in the curriculum. This idea of how do you get unstuck from your black and white all or nothing thinking? How do you understand somebody else's perspective? And for me, as a DBT and dialectical behavior therapist clinician, that is the core of what we do, teaching dialectical thinking becomes so important because our adolescents have this tendency to get stuck relatively easily in this all or nothing, black or white. So we spend a good amount of time at the beginning of the curriculum there. The next thing I just want to kind of show you is this, we call this not the choose your own adventure slide, but this is a map of what the DBT Steps A curriculum looks like in the 30 lessons. And just to kind of walk you through this, I'm a very linear person. I'll show you my next slide, this is Jim's slide versus my slide on how we kind of interact with each other. But it is helpful to kind of know where to go on the curriculum because it is 30 lessons. Is that we start out with the first 2 lessons are our orientation, where we set up what are the classroom guidelines. We talk about expectations for classroom, what the homework's going to look like. But we also spend time talking about confidentiality and the fact that there is none in a Steps A class on that. And we want everybody to respect each other's confidentiality and don't expect it, right? In this day of social media, it will take 1.2 seconds for your best-kept secret to be put out to the whole school. And what we find with adolescents, which you all probably know this already as well, is that our students don't have as much difficulty sharing information. It's actually getting them to not share information is where we spend more time, is getting them to be mindful of what you should and should not share with everybody in the world. So we spend time in the first 2 sessions talking about those guidelines and dialectics. And then we move into teaching the distress tolerance skills for lessons 6 through 12. Then we move into teaching mindfulness for 3 lessons, and then into distress tolerance. for lessons 3 through 12, there is a module exam built in. It's a knowledge test, a knowledge quiz for each of the modules. And then after we teach distress tolerance, we go back to mindfulness for 2 more lessons, lessons 13 and 14, which is very standard with a typical DBT skills group and outpatient, in that mindfulness is kind of our core set of skills that we want to make sure the students can understand how mindfulness fits into using all skills, that you have to increase your mindful abilities. And we actually start every one of the lessons off, starting with lesson 3, with a mindfulness activity, some kind of mindfulness practice that we want them to use from lesson to lesson, so that they're getting that practice and being able to, I call it 2 muscles. They've got to like practice strengthening their noticing muscle. Like, how do you notice and focus your attention where you want it to be? But also your awareness muscle. Like, how do you notice when you're starting to ramp up and emotions are starting to increase? Rather than noticing all of a sudden I'm at an 80 and I'm like storming out of the classroom, how do I start to notice at a 40 or a 50 on the SUDS rating that I'm starting to get a little bit of distress and use skills there? Or how, when I'm really distracted and unfocused, how do I take my attention from over here and keep putting it back? And we spend a lot of time getting them to practice that from week to week as a core skill in the Steps A curriculum. After we teach distress tolerance, we move into lessons 15 to 21 are the emotion regulation skills, where we teach them how to identify and label their emotions, how to understand the different components of emotion, how to change their emotion when they want to change it, and also how do they do the opposite of what they're most really experts at, of distracting, but how do you sit with and experience an emotion, which becomes really important. And so we teach them in the distress tolerance how to distract from emotions and urges when you need to. But we also then spend time over here, how do you sit with and experience an emotion when you need to do that also? That both are important skills to be learned. And then after emotion regulation, we go back to mindfulness for 2 more lessons before we go to interpersonal effectiveness. And the other thing I'll say about the mindfulness is, as we go through this each time, we're not just repeating the exact same lesson. We're repeating the same skills with different activities, different participation, different examples. And as we move through it, that by this last set when we're teaching it, we're having the students mostly teach it back to the class and doing role plays and working together in that. So it becomes more interactive as they gain more skill with the mindfulness side of it. And then in the end, we teach them the interpersonal effectiveness skills of how to ask for what you want when you want something, and how to say no to the things you don't want, and how to improve your self-respect over time, which we think is a really important, to kind of back to one of those protective factors of self-esteem, self-respect that we talked about earlier. And I'll just say one of the things that I really love about the interpersonal effectiveness skills, especially the skill of evaluating options, that in a lot of high schools that we've worked in, where this skill becomes so important, it's about how do you determine your intensity to saying no to something and your intensity for asking and getting what you want, is when it comes to the question of teaching students about consent and peer pressure around sexual behavior, of how do you determine how intensely I am allowed to say no to something, and figuring that out, which should I give into sexual behavior or should I not? What does it look like? And health classes and health teachers we've worked with have found that really helpful, of taking these skills to the things they already have to teach, that is the question on our students' minds of when do you accept no, when do you not accept a no, and when do you really push your no? And just kind of one example of really thinking about that from a community perspective of what are we seeing happening with our students more and more. Teaching about consent becomes really helpful there. And so that is kind of the general layout of the curriculum. But I also want to say it's flexible. We have schools, because this is a universal curriculum, when we put this order together, one of the things we were working with some schools and they were struggling with is, our kids don't make it to November or December or January for school. They're dropping out. There's school refusal happening really early. So we said, okay, we want to make sure we get the distress tolerance skills into our students really early, because they need the skills to tolerate those urges and those emotions and able to keep their selves in schools. And so that was why we put that there. But now we've worked with some other schools who say those behavioral problems aren't the difficulties of our kids. They're not dropping out of school, they're showing up. And so it's harder to engage them in the distress tolerance module. at the beginning. So we say that's totally fine. Skip distress tolerance, teach them emotion regulation first, teach them about the model of emotions, and then come back to distress tolerance after. There's flexibility in the curriculum in that way because we want to meet the needs of our students and not just try to shove a curriculum and one more thing they have to learn down their throats, but how are they going to find it helpful and meaningful? And I just say that because if you're thinking about implementing it or you're already implementing it, I want you to know you have that level of flexibility in putting the curriculum together. So I'll just show you, this is my slide, right? Goes in order. Here's this curriculum in that way. Says pretty much the same thing, though, of the skills that we teach and how we go through it. Couple more things I'll say before I'm going to pass this over to Jim in a little bit and just walk you through, is let's just talk about what are the goals of the DBT Steps A class. You know, in the short term, we wanted to kind of develop a structured format on how do our students learn skills in what we call this non-judgmental environment. In this non-judgmental environment, kind of really thinking about that. And we spend time a lot at the beginning, and we're teaching mindfulness about what does it mean to be non-judgmental? How do we kind of develop that culture, develop that language with our students? To give them a set of skills that they get to apply to their own personal situations. One of our goals and what do we think about is like, you're in math class to learn math. You're in your language arts class to learn how to be a better writer, to understand and comprehend curriculums. And in your Steps A class, our goal is for you to be a better you, a more effective you, right? So that you're applying it to your own personal situations and difficulties. And then we want to also provide ongoing, what we call coaching and support during skill development, because now if one teacher or eventually an entire school understands the skills, we can all support our students in being more effective, skillful behavior. In the long term, we want them to have the opportunity to practice skills over time so they become more automatic, and especially at this critical development period of adolescence, we have the opportunity to teach them skills early to kind of start shifting how they may respond in their long-term adulthood. We want them to have lots of practice so they can polish their skills. We give them opportunities for practice and generalization through homework and homework review in the class. And then, like I said, ultimately, we want to work towards an environmental shift in schools adapting the language of DBT Steps A. And peers are doing peer-to-peer coaching and feedback. Math teachers understand the skills, so when a kid's struggling and wanting to give up on their math assignment or their test in the classroom, the math teacher can start suggesting, like, okay, what skill could you use right now? Do you need to use a tip skill? Because there are mindfulness exercises you could do to take a moment to get yourself refocused on taking your exam or doing your assignment. Shifting that culture over time is our goal. Let's pull these up. So what the curriculum looks like, just to give you a brief overview here for a moment, is that the curriculum is designed in general for universal, but also really fits the multi-tiered system of support model. And Jim will talk about this in a little bit about what those different tiers look like. But ideally, we want a health teacher teaching the curriculum. And it can also be taught by the professional staff, our school psychs, school counselors, school social workers. But the reason why we say the ideal teacher or any general ed teacher is because one of the biggest barriers we have in schools is being able to push into an academic classroom. Right? So if there's a class where it's already in there, it gives us more space. It also is because we want to move away that our mental health staff have to come in and teach the mental health class as if it's something different and special, keeps it separated from the general academic curriculum. If we have it that this is social-emotional learning, it's a part of our school's environment, then one of our general ed teachers can teach it. And the curriculum was written in that way that you didn't have to be an expert in mental health to be able to teach these DBT Steps A skills. And so we have schools all over. We've got math teachers, social studies teachers, health teachers, PE teachers teaching our Steps A curriculum, and it was written in a way that they could understand it and provide it to the students where they already have the space often in their academic calendar. So that way all the lessons are manualized, where they kind of are broken down to walk through, like for the first 5 minutes we're going to do this, and then 10 minutes you're going to talk about this, and you're going to spend 3 minutes on this handout and an overview, and then here are the examples and the exercises you can do in class as you teach it. And I'll show you an example of that in a little bit. There's the teacher manual with the fully written out 30 lesson plans, and then there's the student workbook that can be printed out and distributed to the students that have all the handouts and homework sheets for them as well. Each class is designed for a 50-minute period. We kind of went with like what was the average length of a class in middle and high school. There are 30 lessons. They're flexible. And they're, like I said earlier, they're standardized with the Rathison-Miller DBT curriculum that they have. But this idea, when I say that they're flexible, not all schools have 50-minute classes, right? We were working with schools in County Cork, Ireland, where their classes are 35 minutes long. So we had to work with them on how do you adapt the schedule. So maybe they're teaching one lesson for every 2 classes instead of one class. But then we have other schools like they've got 65 minutes. So how do you do more practice? How do you stretch it out? How do you get more examples and exercises? So that flexibility is built in there. Our goal is that we teach the kids the skills and they get to practice the skills, not just kind of get through the curriculum is our ultimate goal over time. So it's kind of just what I said, how we're broken down here. Every lesson includes what are the main points of the lesson, what are the materials needed for each lesson, what provides an overview and timeline outline so that it can be easily referred to as they're walking through it, detailed lesson plans including examples and homework assignment. And so every lesson is structured the same way with the same format. With the idea, and there was lots of cutting and pasting between each of the lessons because sometimes teachers are absent and they have a substitute, and we wanted any substitute to be able to pick up the lesson for that day and to be able to teach it with having all the information right in front of them. And so that's kind of what that looks like. And so before I stop, I just want to show you some printouts from the manual of what an actual lesson looks like to kind of so you can see it. And so this is our lesson number 9 from the distress tolerance module on the pros and cons. And so you can just see that every lesson starts with, here's an overall summary of what this skill is that we're going to teach today. So you kind of just have that going in. And here are the main points we want to make sure you communicate to your students when they walk out of here. And then there's a list of materials, and they're all pretty much saying which handouts you need for this lesson and worksheets. Everybody, we want to have like extra skills binders, pens and pencils in the classrooms because students often forget their materials. They forget their notebooks. We have a 11-year-old in 5th grade, and he's in his first year of middle school. And just this ability to learn how to organize himself and move from class to class and remember his books has been quite a challenge, right? And so like, how do we have backups when they need them as we're trying to teach them some of this organization? But specifically, one of the reasons I chose this lesson to show you all, because number 4 says, you also need 1 small piece of chocolate for each student for class today. Not all the lessons require chocolate, but it's this idea like we're going to do a mindfulness exercise in this lesson, and we're going to use chocolate for it. So we didn't want the teachers to be reading through, and all of a sudden they're like a quarter of the way through the lesson, like, oh, there was something I needed and I didn't know about it. So we tried to kind of break it down in that way so they were all prepared. And then what do they need to do for preparation? And then this is just the general outline and timeline for what the lesson's going to look like. And you might just see that, like here, we're going to spend 5 minutes on the introduction of the main idea, but we're going to really spend 25 minutes on the discussion. 5 minutes is on the review of the handout, but 20 minutes you're going to spend on the exercise. To kind of giving this breakdown based on a 50-minute class of how much time you should spend on things, because we were finding that when we didn't break it down that way, sometimes somebody was spending what I expected to be a 1 to 2 minute overview of an introduction. They taught the entire lesson from that page, right? So it's really kind of giving those guiding principles as they walk through it. And then, so here's kind of the detailed lesson plan. This is where we go through the mindfulness exercise. Everything that is in italicized here, that's kind of what we call the script of what to say to set up the exercise, to go through the discussion points. And it's not a script that you are mandated, that you actually have to read it out loud. It is a starting point for teachers and who have no experience with DBT Steps A, leading a mindfulness exercise, teaching the skills of here's what you could say. And we have found that that has actually decreased the anxiety of many of our teachers to know that they have a script, that they can read it, and over time they put it into their own words. And then we walk into the actual lesson plan, going through, say this to students, and then allow them to have some discussion and answer, and then you can say more, and then here's the exercises you're going to use. The piece that's also, again, that flexible piece is not that they have to say all of my words that I wrote down. It gives them a guiding piece. There's flexibility in that we tried to write a universal curriculum for students in Ireland, students in the inner city Bronx, and students in Iowa, right, which have large population differences. And we talked to our teachers about figure out the examples and the exercises that make sense for your student population. There's that flexibility in there. Stick with the principle and the rationale behind the skill, and how do we teach that to our students? And so this kind of just continued. You can see the italicized, the question points we wanted them to put in there. And then a lesson summary, and then we teach homework on all of that. And then the final thing we have is what we do use for progress monitoring. In standard comprehensive outpatient DBT, we use a diary card to track emotions and behaviors and skill use in our students from week to week. And so we wanted to take part of that progress monitoring piece from outpatient DBT and bring it into Steps A. So we use what we call the DBT skills diary card that just focuses on skillful behavior. This is a list of all the skills that our students are going to learn in the curriculum. And we want them to be circling and just like, did I even try this skill this week? Did I practice it at all? Right? So it's one way, as they turn this in each week, the teacher can see, are you practicing skills? Are you thinking about it? It's also a quick reference guide for students to be able to look at to increase their awareness and thinking about skills from week to week on this. And we've had schools do this in different ways, where some teachers look at this and students look at it like, that's too much, that one page is overwhelming. So maybe we'll have them just highlight and just focus on the skills they've learned so far, and every week when they turn it out, they just have a line on it. They're like, you've learned these skills, so just focus on the ones above the line and get some flexibility in that. But we really work with the teachers on use this for progress monitoring, for understanding, but also increasing mindfulness awareness for our students as they kind of go through it. So that's kind of just in general what the curriculum, our background and development on it, kind of why we put it together and what it looks like. I'm going to turn things over to Jim now so he can kind of walk you through a little bit more of our implementation of it.
Can people hear me? Turn it on. Is that better? I'm not sure how Liz stayed by that podium all that time, but good for her. Notice the urge and you stayed there. That was great. Opposite action. All right. So, great. That's kind of our progress monitor. I'm going to kind of come back to where we are now with schools and kind of our triangle. So I'm coming from a multi-tiered systems of support. How many people here are aware of what that is, or schools are doing it? A couple of hands. It's actually kind of a continuum of services that we're offering. And instead of saying, okay, general education and special education, which are two distinct categories, we're saying, look, everybody can use some skills. Everybody can use some additional programs, services, and so forth. So a multi-tiered systems of support provides us some of that ability, all right? And so here's how schools currently usually sit. So this kind of this pinkish brown triangle here is universal population here. So tier 1 selected and indicated. Here's our first 3 tiers in what we call in our general education. We have special education teaching, right? We have special education category. We actually hire people that are special education teachers. Do I have any special education teachers in here? Seeing no hands. All right. But we hire these. These are actually some of the first people that get hired in our schools because federal dollars are tied to special education. And so to get access to federal dollars, the kids that have higher needs, this gets hired here, right? Our special education teachers often, though, don't get training in mental health. So you ask a special education teacher how to deal with someone who's self-injuring or someone who's having emotional dysregulation, they tell me they don't. They just refer them on. So our school system's not helping that way, all right? And so in this section here, make sure I do here, so we have kids that are at general education, we move up the ladder, school psychologist is here, we develop an IEP, goals for the students, and then they come over here to our special education teachers to get more intensive services. The problem with this current model, all right, and this is all within the schools, is that it is adhering to a WTF model. What's WTF? Don't say it. Waiting to fail, okay? By the way, schools do the other WTF too, just don't get me wrong, all right? So we wait for kids to get worse and worse and worse, and as a school psychologist, we can't identify their learning disabilities until the gap gets so big that it comes out statistically significant. Now that's kind of crazy. And so when Liz and I were talking about this conversation, and Liz was pretty adamant this was going to be universal, and I was pretty adamant it's not, and so we had this discussion, it was becoming really apparent that these adolescents that Liz was seeing was a WTF model, waiting to fail. These kids had to get worse and worse and worse before they can get an evidence-based intervention. I'm like, that's the other WTF. We got to stop doing that. And so most schools have it set up this way. If there's social emotional needs in the school, they often get assigned over here to outpatient therapy, all right? And outpatient therapy is great. However, we know that Stephen Kilgus's research in 2015 showed that of the 1 out of 4 to 1 out of 5 kids who need mental health services in this population, 80% of those kids who need it don't get it if it's referred out here. They don't come. Even if Montefiore is great, right? And Alec does a great job there, or the internship does a great job, Columbia does a great job. It's buses, it's time after school, it's parents who have maybe several other kids. They have to travel 40 minutes for a 50-minute appointment, 40 minutes back, and oh, by the way, get dinner and homework. What Stephen Kilgus was able to show that when that same system was offered within a school, 96% of the kids who were referred for mental health services got them. So it's an accessibility issue, all right? So we have to work on some of that. And that's where we have to work with our community partners. What's interesting here is this beautiful green spot here is this unbalanced approach, and we're now working on the academic child here. We do this here. If they need added services, learning disabilities, we are pretty good at it here. We're not very good at helping kids who have anxiety, who have depression, who have undergone trauma. So what we can do, what I want to do, is balance it out with another triangle. What we'd like to see done, ideally, is have a mental health services piece here that matches our special education piece. This side can work on academics. Fantastic. This side can work on mental health. And guess what? We might even actually talk to each other. Wouldn't that be nice? All right? So the IEP goals should have goals that are mental health goals and educational attainment goals or academic goals, right? We've got high stakes testing in New York, do we not? Yeah, on the academic side. Do we have high stakes testing on the emotional side? Not yet, we're getting there. July 1st, the standards go into effect for secondary schools, SCL standards. We would like to have the schools hire people, just like they hire special education teachers, to hire mental health professionals. That'd be kind of cool, right? There's a lot of people, even a lot of clinical psychs, who like this model because they get summers off. They don't have to pay for their health care, right? And their day is done basically at 3:30, 4 o'clock. And so it makes some sense that we could actually have this and have these school-based mental health professionals working under a school district, all right? Then, if this system doesn't work, these 3 tiers, and these 3 tiers don't work, then they can do outpatient therapy, right? What this offers is another set of abilities for outpatient, for services for happening under one roof. At Tier 5, what's interesting, if we have residential treatment centers that are going to work on mental health, we have schools built into there. And if you have academic issues, we have mental health built into the treatment schools. It's not till Tier 5, which is our waiting to fail model, that we start to integrate them. Why do we have to wait to Tier 5? And at Tier 6, I know this is a hospital. At Tier 6, there's not a lot of learning that takes place. The educational curriculum and the schools really doesn't function well right here. So this is a lose. And we know that kids then that come out of the hospital and there's no discharge transition plan between hospital and school. They go all the way from here, Tier 6, to down here, Tier 1. That's a setup for the kids coming out of the hospital. No services to very, very, very intensive services. We got to stop doing that, right? That's not going to be helpful to our schools, not going to be helpful to the kids. And so this is our ideal model that we have, all right? So what does this look like if it's DBT? We have DBT services that happen all the way through here. So here's Steps A, here, all the way up. If Steps A is not strong enough, not intense enough, at the Tier 3 level, school psychologists come in, do your assessment, cognitive, academic, social, emotional, IEP goals, and some of those might be that they need individual therapy. Okay, now we've got school-based DBT right here. Rathis and Miller, and we can have some of the schools that we talked to earlier this morning, you're actually doing some of the DBT therapy 101 within the school setting. That's the ideal place to be, all right? And maybe that's not strong enough, and they might need, finally, outpatient therapy. Could be. But in this model, at least, when we look at a multi-tiered systems of support, if we have a school that's 2,000 people, all right, and at Tier 3 is roughly 5% of the population who need Tier 3 services, we now have, in my quick math, 5% of 2,000 is 100 kids. This tier is perfect for 50% of those kids. That means 50 kids come over here and you need tier 1 school-based DBT. It's the right level for half of them. Now I'm at 25. It's the right level for half of them. Now I'm at 12 and a half. I'm going to make it 12. It's easier, right? That means this is the right level for half of them. I have 6 kids that need services over here. Is that what our typical high school has? 6 kids of 2,000 going to outpatient therapy or needing mental health services outside of schools? Likely not. It's usually somewhere between 75 to 150. All right? So we need to be cutting those things down. Right? Let's make the school more accessible for those services. So here's where I think we currently stand. All right? Our schools are set up for academic success. We have something called social emotional learning curriculum. People familiar with that at all? How about CASEL? Familiar with CASEL, right? The Collaboration for Academic and Social Emotional Learning. Really helpful. We're having a disconnect, though, between mental wellness and where our current school curriculum are. And when I teach in the school psychology program, I keep saying, okay, there's an issue. What is the issue? What's the gap that we have? Is it a performance gap? Do they have the skills and are not motivated or not performing the skill? Or is it a skills deficit? They don't have it. We have to teach them that skill first, and then they can perform it. Which is it? And often, when it comes to emotion regulation and adolescence combined, it sits here. It's a skills deficit. And I'll bet you if I look in this room and we go back a month's worth of time here, any of you had any time when you got really upset maybe with a partner or a football game or something else where you were pretty loud? Right? We emotionally dysregulate. So we need to teach that skill. All of us can still use some of it, right? And then we polish it and polish it. So we have some of that automaticity that Liz was talking about. So we're missing this piece. So how do we start to move one of these bridges over to connect to the other? Mental wellness is where we need to be. And DBT Steps A isn't the only game in town. We want to work with positive behavior intervention supports. That's a system-wide approach. We can work with other types of SEL programs that are there so that we match and get to this bridge over here so that it's a clean highway. All right. I talked about CASEL. This is our authority in social emotional learning. This is a group of people really smart that have established a high bar of programs that they're going to endorse, right? They have shown in at least the middle school the issues in which programs, in which these these 4 programs have success or where their data or where their standards are. What's interesting about this middle school set is that there are 6 programs. I have only 4 up here. There are 6 programs identified by CASEL. There are 23 for elementary school, and there are 5 for high school. So we've gone down the number of programs that are successful in treating or in establishing some type of intervention in these areas. So here's expeditionary learning. So you can see increases academic performance, decreases problem behaviors. Those are all good. Increases positive social behavior, SEL skills, good. Emotional distress. Not a single middle school program that CASEL has endorsed actually aids in reducing emotional distress. That's a problem. How are kids dying? They're not dying from their learning disabilities. They don't even die from anxiety. They die actually from their emotional dysregulation, maybe due to anxiety, maybe due to depression, because they self-harm, right? So we're missing that. Well, how about the high school program? Right here, same gap. Look at it, it's completely missing. Every one of our high school SEL programs increases academic performance. Do I have any principals in the audience? Superintendents? So you have to close your I don't care about this one. I really don't. Not as a mental health person. Do I love being able to tell this person, oh, I'm going to help you increase GPA? Oh, yeah? It helps people get to school. Yes, it helps school connectors. Great. What I want to do is reduce emotional distress. I want to reduce decisions that are being made on emotional dysregulation, because that's when they cut. That's when they attempt suicide. That's when they punch somebody and get suspended or expelled. This is where we are trying to put our efforts, all right? You can open yours. So as Liz was talking about, we have a model or a structure often that is looking at mental health illnesses or symptoms, right? Are my school psychs in here? Did I have any school psychs in here? We left them all back upstairs. And oh, there's one. Thank you. We use what's called some broadband measures, right? Like our BASC or our CBCLs, and we identify pathology symptoms. If we use that model, right, that means a lack of pathology must mean they're really happy in their lives. That's not the case. Lack of pathology does not mean mental wellness, right? And Shannon Suldo, who is out at the University of South Florida, has been really instrumental in trying to say, you know what? It's not enough to look at pathology, because lack of pathology does not mean great mental health. What we have to also look at is the perceptions of that child's well-being. Do they think that they're doing well or not? So she produced a quadrant here that used subjective well-being as a second factor, so a dual factor model. And what's interesting here is that we have kids who show very little pathology who do not feel good about themselves, all right? We miss those in our current school psychology lens. And so we have a group over here who show very few symptoms on our BASC or CBCL or our DISC who think that they're not doing well. This could often be our gifted kids who are just lights out great academically and feel like they don't belong, right? I go back to the issue of, or the movie Wonder. Who's seen Wonder? Yeah? At risk on our BASC? Probably not. Lights out smart? Yes. Vulnerable? Absolutely. We miss those kids. So we've got to find our way to get them. Over here, we have kids that come up high on our broadband measures. We can identify them. We often can identify this group here. We'll get some of these people here. What's interesting is that the kids that show some symptoms but have good coping strategies do pretty well. With a little bit of help, they actually go this direction, Shannon's been able to show. This group here, because we don't identify them, and our adolescents think that adults know everything, because we give them that information, that we know everything, they go from here to here. So if we use our dual factor model, we increase our battery as school psychologists to ask a simple question. How do you feel about your life? Do you think things are going well? Gives us their subjective well-being. Keep in mind, it's their perception. Because we often have people who we just assume they've got the world by the tail. The valedictorian, the top athlete who dies from suicide. And that actually happens to be one of my best friends who died from suicide. Valedictorian, 2-time state champion. Every teacher thought he was doing great, and at age 16, he wasn't. And he was talking to me, he was talking to some of our friends, and the school did nothing about it. All right? Those are the people we're trying to reach. So we have to kind of change our lens there. This is the farm picture that Liz had talked about a little bit before. Our current school structures have siloed health classes where they teach risky sex, suicide prevention, drug and alcohol, bullying. They don't talk to each other. Oh, we're done with that curriculum. We're done with this book, next book. And what you learn in risky sex doesn't work for suicide prevention, doesn't work for drug and alcohol. Siloed approaches aren't very contiguous, right? They don't talk to each other. And so when we've talked to health teachers, they're like, yeah, I put together my own program. I put together my own curriculum. Well, how do you know it works? They said they don't, right? They just have to cover these things and check off the boxes for the Washington State standards. So what happens, though, if we've had a common ground here where all the silos could stand upon that had a coping strategy in decision-making? Because you're still going to have coping strategy in decision-making about risky sex, about self-injurious behaviors, about drug and alcohols. And what if that was the Steps A curriculum because it focuses on emotion regulation? What if the language in DBT Steps A can now be used when they're thinking about suicide and we say you should use an opposite action skills or use a tip skill? That's not there if they just pull this silo and teach it by itself. You can use that same tip skill if it's over here in drug and alcohol. You can use the same opposite action, wave skills. So you give a common language for the students to be able to talk to each other and the strategies to use for now all of these. So these silos can be laid on top now of a common ground that talks to each other. So that's where we think that when principals and teachers say, we have no room for this, we say, well, I beg to differ. Maybe what you can do is have it as part of like a health class or part of some other wellness class where they're going to talk to each other here, right? And that way, it's going to make it much more meaningful and have continuity to that the bullying prevention program actually is related to risky sex and is related to suicide prevention through this piece here, right? All right, so common barriers that we've seen from schools. Personnel resources, there's not enough of us. Absolutely true. All right? Teachers say, you want us to do one more thing? Are you kidding me? I'm already doing too much. Absolutely true again. So how do we deal with that? Allocation of time. Where is this going to fit into the schedule? All right? Need for follow-up. All right? So meaning, how do we keep supporting teachers once they start doing this? Administrative support. Are the principals bought in or not? If the principals and the superintendent are not bought in, it's not going to work. It'll be like swimming upstream. And even if you're Michael Phelps, sooner or later, you're going to get tired. All right? And then financial support. How are we providing support for some of those teachers? All right? And then politics. And like that should ever come into play, right? School and politics and school and community. So we have some, what will I say, some challenging ideas being put forth for teachers about how to help keep schools safe, right? Politics plays a role. It'd be kind of foolish for us to think that politics does not play a role, all right? How do we do this in schools that are different than what Liz and I were used to, that we wrote for? We want schools to adopt the idea of putting SEL into their schools, into the environment. And then we want them to adapt it. Now, what does that do from a research standpoint if they're adapting it? Well, it's not perfect, right? The fidelity of that is going to come down a little bit. They're not reading the same words across Iowa to Ireland. All right. But it's more important that the students learn the skills and get traction with those skills. And we need the teachers to adapt that to their classrooms, to their student needs. The skills stay the same. They have to adapt the language. They have to adapt the examples. All right, so that becomes really important so that we have an adopt and adapt. We think we have a balanced approach in that we want DBT Steps A to be individualized. It's individual learning the skills. It's teacher supported. And it balances with schools that have PBIS. Anybody doing PBIS? Yes? Great. So we're not asking you to get rid of PBIS or your school-wide programs. We're not asking you to get rid of Ruler. Anybody doing Ruler? Okay? It works. These are system-wide approaches that are great. But ask a kid who's emotionally dysregulating what their PBIS skill is to calm down. What's your skill? Just calm down, right? And of course, you too. You like it, right? When you're in an argument and someone says, just calm down. You're like, oh, I feel much better. Yeah, that worked. Great, right? Doesn't work that way. And so if we can have skill specificity to work in reaching the goals that the school establishes through their PBIS, they're going to work lock and key. That's what we want. All right? Same with Ruler. Right? So it's a balanced approach. They're complementary. So preliminary results. So what does this look like? In a alternative school in Washington, these are kids that have already blown out of their public schools. There were 5 suicides in 18 months in the school district down there. The last 2 were 8th grade girls, best friends, died from suicide, 1 month apart, same method. And they're like, enough, we're done. Right? And that's often when we hear about schools that want to get some of the training is after the fact, right? This is, again, WTF. And this person who's an alternate school teacher, in the Washington Healthy Youth Survey, he was seeing 10 to 12 middle schoolers self-harming per year. Implemented DBT Steps A for the first time in 2014-15. We saw 3 and none since. I'm not saying cause and effect. All I'm going to say is I like the direction. All right? Something seems to be different. All right? So we'd like to keep doing work with that school. Here's some of the data that we've received from Ireland. So here, DBT Steps A sits right here, right? This is actually school-based DBT. This is actually getting intensive services within schools. What I want to point out to you on this is that way down here, when students are really probably at that tier 3 level, maybe some of these are going to be tier 4, right? We're bringing in tier 4 services into schools. These students who received school-based DBT caught up to their cohort in emotional regulation. Look at these lines are just about the same. So this does work, providing intensive services in schools. Keep them in schools, right? And then you can use DBT Steps A as the boosters to continue, and then they're not in therapy or they're not in school-based DBT for 3, 4, 5 years at a time. So real important, you can see statistical significance. This is this is fall, this is spring, so it's an academic year. Here's the Basque results. Increased self-esteem significantly. How about self-reliance? Not so much. Why? Our curriculum's not designed to teach self-reliance. We think you'll get more independent and self-reliant with the more polishing and the practice of skills, but from a pre-post level, it's not there yet. The direction's good. not there yet. So we weren't surprised to see that result. Basque again, significant differences here in anxiety. Not so much for depression. The trend's right, but we're not going to have an immediate impact on depression level. That's not what it's designed to do. It's designed to have an immediate impact on skills to help deal with maybe some of your depression that's there. Atypicality, which is a catch-all category in the Basque, I won't even get into that. This is the big one. The emotional symptom index, which is a composite score, big significant differences here. So we're making a difference, and you can see it's a little bit different for our boys. They didn't show nearly the same impact as our girls did. Well, if we look at some of the scales that are depression, sense of inadequacy, anxiety, self-esteem, we know those issues tend to be more female-related than in males. Making a big difference. We also know that girls attempt suicide more than boys, and girls cut more than boys. So we do want to have that type of piece there. So that's in the right direction. For the sake of time, I'm just going to say this is an interaction effect. More kids here were less identified by the end. So we had more kids that were let me try this again. Get my words twisted. There were less kids identified at risk by the end of DBT Steps A in the DBT Steps A group. There were more kids identified at risk in the control group. So there's an interaction effect there. It's in the direction that we were hoping for. All right, what if it doesn't work? What if DBT Steps A doesn't work at that first level? Well, we've got strategies at the Tier 2 and Tier 3 level, right? Right here. And so this isn't choose your own adventure either, all right? So, but what happens is, here's Tier 2, smaller cycles, smaller groups going around in the cycle or taking 2 class periods for 1 lesson. Spend more time on it. That's a good thing. And then have the individual instructor available on an as-needed basis. Someone's asking somebody out on a date, they could use some coaching. There's a state championship football game, they could use some coaching. Have something that's an on as-needed basis. That's Tier 2. All the Tier 2 strategies go back into here for Tier 3. We have designated individual time. That's not therapy, but just coaching and modeling time. Parents get involved. We know parents are important. We want to educate the parents about what is in that SCL curriculum, what modules are on, what skills, and to be patient with their youngsters at home, all right? And then team support for the teachers, really important. I'd love to see this at the universal level. But being able to have protected time for the teachers to vent, talk about kids that are pushing their buttons, talk about strategies that worked or didn't work and why, that's protected time per week for the schools. And keep in mind, if that doesn't work, we still have school-based mental health. We have another 3 sets of tiers of intervention to provide before outpatient therapy is recommended. And then, of course, in an MTSS system, we always want to progress. Are we making a difference? How do we know? All right? And, all right, before I get to your questions, I'm going to leave you with this slide. Oh, that's not the slide. Next one. I'm going to leave you with this slide. How many people here know about the Lorax? All right? How many people here know this Lorax? That's mine, right? Old guy. Here's Danny DeVito, the Lorax in the movie. Lorax, great movie for you to actually show clips of emotion regulation and emotional dysregulation skills. You can use it in your schools. Last page of the Lorax, the book. Unless someone like you cares a whole awful lot, nothing's going to get better. It's not. This is my favorite childhood book. The thing that bothered me, carried some of my anxiety throughout my entire, did the truffle trees ever make it back? Did it work? What happens to that seed? That's what I kept asking myself as a kid. And the movie, which I love about the movie, is that the answer is yes. The truffle trees do come back. Who's watering the truffle trees in the movie when they're coming back? Anybody know? This is going to be homework for you today. It's going to snow anyway. Just go watch the Lorax. I'm sure it's on Netflix. Anybody know? The Onceler. The Onceler who chopped them all down is the person watering the saplings of the truffle tree. And I think it's really apropos that these kids aren't damaged. We can make differences. And that we can foster growth in these kids with the right care. And so I want to say thank you to all of you here making a difference, because unless someone like you cares a whole awful lot, things aren't going to change. They're not. Now we'll take questions.
Thank you guys very much. We have sort of a tradition of folks speaking up, so we have about 10 minutes for questions. Let me first say that was just a lovely presentation, very inspiring. Certainly makes us care a lot in this moment. I think now our mission is to carry this forward. But one of the things that people are often struck by transitioning from a typical hospital clinic setting into the school-based setting is the difficulty in engaging with families. And it was something you addressed very early on, Liz, but I wonder if you could talk a little about how some of this translates back home and how you experience that challenge.
So one of the things I'll say, and getting it back home is it's about school engagement. And I think about, and similarly, how schools are communicating with their families. What information are they bringing back and forth? So it really comes down to, are they holding parent seminars, bringing them in, and getting some buy-in from the parents as like, this is what our school does. Not, here's just an extra class we're putting on your kid, but we are a social emotional learning school. We are a wellness school. We are educating the whole child. And being able to provide that rationale early on and get buy-in from the parents that that's what they want and that is impactful and important to their students is one of the places that's made the biggest difference. Because once they've done that orientation, then we can then be sending home flyers, handing out handouts, telling here's the dates that we're going to offer our parent seminar so you know what your students are learning so that you can bring this into the home as well. And then the key is not only offering it at Thursday night at 6 p.m., but it's on Thursday night at 6 p.m., it's on Saturday at 2 p.m., and getting the schools and engaged enough that how do they want to bring in their community and make that a practice as well.
I'm going to add to that. I think that one of the things that we also have to do is start to change the lens of what parents see as schools. And actually right now is a very, very good time to do that because we're very sensitive right now having school shootings. We're very sensitive to mental health issues and the results of not intervening earlier. And so what we want to do, like Liz says, we want to communicate to parents and to the community that our schools are about educating the whole child. That means coping strategies when they get a B+, if they wanted an A. It means coping strategies when someone's called them a name that they don't like, right? We're not going to the place of resolving things through violence. And so we're going to educate that whole child. And I think it's a cultural shift that we have to have. And for a long time, schools are the 3 R's, reading, writing, and arithmetic. And so we're going to need to do that. Some teachers and some parents are going to be upset about, schools are not designed to do that. Don't teach my kid about sex. Don't teach my kid about, X, Y, and Z. And so, but I think the majority of the parents want their kids to develop coping strategies and emotion regulation skills. And so now we're just going to put it on the radar to do that. Yep.
One of the interesting things I find with my school is we have 4 R's, we have second steps. It's delivery,
Yep.
right?
Yep.
So what kind of professional supports do you or can you provide to support this program? We're piloting it in 6th grade, in the oncoming months.
Great. 4 R's, second step, which is actually out of Seattle. Great programs. Keep them. All right. How we provide support is that when we first started doing some of our trainings and the schools would say, yep, thank you for your 3 days, bye. And then when you hear from them for an entire year, they'd say, we had problems here and here and here. I'm like, why didn't you call? And so now we're building in consultation. We know from implementation dissemination science that programs that are one and done don't get done later on. There's no follow-up. If we can coach and help the teachers and the administrators through some of the rough parts, especially at the beginning, they're more likely to do that. They're more likely to be implemented with fidelity. And so we now put in, when we do our trainings that they have in our contract, they have to find a time for us to consult with them to help on the difficult kids, to help with the difficult lessons, to help support them so that they're not feeling like an island out on their own. Does that help? Great. Other questions?
Thank you so much. That was a really fantastic presentation. And I truly believe in your interventions before young people get to college, but I'm going to ask you about college. So we're clearly having a crisis across the country at undergraduate and graduate levels.
Yes.
In terms of mental health, in terms of, and also in terms of sexual misconduct or
Yes.
gender-based
Yes.
misconduct. And so I'm listening to a lot of this thinking so much of this might be appropriate, better to start early, but have you expanded this in any way or thought about that?
He can tell you all about that.
Yes, and much to my time allocation dismay. So here's what's happened. So as we were developing this, it became apparent working at the university. So the University of Washington, I'm sure Maria Kowski, the president, probably doesn't want me promoting this or saying this, but we've had 15 suicides in 5 years at the University of Washington, right? None of that ever gets published. We get emails about strong-arm robberies. We get emails about assaults here and there. Nobody knows about the deaths on campus, all right? So when we've been able to start to collect some of this information, because we've been working with the JED Foundation that's here out of New York, we came up with this, we saw this number of 15 in 5 years, and when we looked at the average, we were dead on the average. I'm like, oh my gosh, we're average? That doesn't work. So what's going on? So I've developed a class that takes these skills and then supplements them with gratitude. Still there? Yeah, with gratitude and some other resilience skills. And now I teach a class that is called Resilience and Wellness for College and Beyond. And it has received a lot of support. And so our resilience lab at the University of Washington, our sexual assault and prevention of sexual assault group has all supported. We've the assistant vice provost of the undergraduate school wants to make this mandatory for all incoming freshmen and all transfer students, especially international students, where if the culture's new, trying to figure out their lives is new. We've received a lot of support. It used to be 1 quarter per year. It's now 3 quarters. It's all 3 quarters per year. And now we also have broken it down. Instead of just giving you content, talking to you, we've broken the class apart into a content section where we talk to you, and then you have to practice the skills, kind of like a DBT Steps A group. And so now
it's a lecture class and a lab.
Correct.
The students have to attend a 1-hour lab once a week where they actually practice the skills themselves.
They do get an academic grade, so it helps them, especially kids that might be, whose GPAs are low. The athletic team is now pushing, the Department of Student Athletics is now pushing our class as well, because their athletes are going through a lot of anxiety, emotions when they're not succeeding at what they think they should be doing. These are scholarship athletes. And so, again, we're seeing a lot of traction there. We're into the hundreds and hundreds of students per quarter now, versus when we started off, it was like 30 to 35. Other questions?
Hi.
Hi.
How you doing?
Good, I'm doing well.
What about along those lines? What about jail? Oftentimes, emotional issues, especially in urban environments where African American and Latino kids go to school, they're criminalized and they wind up in jail. So, is there any plan to expand this into serving that population?
Yes, I'd love to expand that population, because some of our incarcerated institutions have schools within them. And those kids need to have some of these skills. It may be the reason why they are where they are at this point. And teaching them skills like this and to have an opportunity to practice those skills can help transition them back to our society. And that's what we need to be doing. They're very productive people if we can give them the right skills and give them the moments and opportunities to practice those skills. All right? And so let's give them that chance. So I've had several people that have been in juvenile detention centers wanting to be able to include this type of curriculum. With that said, they're not going to come in at tier 1, though. We should be giving them individual time with whomever therapists in the jails, and then teaching as a group the skills, because we do want peer-to-peer interaction happening there as well. So absolutely, I need to find my cloning machine first.
And there are many juvenile detention centers and jails and prisons that are using comprehensive DBT in their programs as part of their step down. Like in Middletown, Connecticut, I don't know the appropriate, we called it kiddie jail, right? Their adolescent detention center is like they have DBT programs. So on a clinical base, there are many detention centers who are using it.
So unfortunately, though we could probably keep on going for another half hour or more, we need to stop and thank Jim and Liz.
Thank you, guys.
And then upstairs, in 2 minutes or as soon as you can get upstairs, there's lunch. More opportunity to ask questions and interact. Thank you.